Yeah, look at all those participants, 88 participants. Wow, that's pretty good.
These are very well attended rounds, Dr. Weitz.
Yeah.
So I'm really excited. I think people will really enjoy your talk.
You guys don't talk, right?
No, we don't have.
Oh, you're on mute.
In the interest of time, Aditya, I think we should get started.
Excellent. Okay, so hello and welcome everyone to the University of Toronto Transfusion Medicine rounds for April 22nd. Today is Earth Day, so happy Earth Day. Today we have a talk from Dr. Ilene Weitz. She'll be discussing the clinical aspects of cold immune hemolytic anemia and the advances in treatment. Firstly, I want to thank ORBCON for sponsoring and facilitating these rounds. These rounds are made possible by support that we receive from various organizations, including Alexion, CSL Behring, Grifols, Octapharma, Orthoclinical Diagnostics, or Takeda, and Instrumental Laboratory. So the video conference event will be recorded and archived, and excerpts may be used for educational purposes. By participating, you indicate your consent to recording, archiving, and use of educational for that use. Everyone is invited to take a moment to complete our feedback survey at the end. There will be a link in the chat box during the presentation, and it'll be on the final slide. And we really value your responses. It'll be used to help improve our rounds. So today, we please welcome for us Dr. Ilene Weitz. She is a professor of clinical medicine in the Division of Hematology at Keck University of Southern California School of Medicine. She attended the Medical College of Pennsylvania, did her internal medicine training at Cedars-Sinai Medical Center in Los Angeles, and her hematology fellowships at Scripps Clinic and Research Foundation. Her research and clinical interests include hemostasis thrombosis, complement disorders, including PNH, complement-mediated HUS, cold agglutinin disease, aplastic anemia, iron metabolism, hemoglobinopathies, and immune-mediated blood disorders. She has published multiple original articles and reviews and chapters on these topics. She also received the Faculty Teaching Award from University of Southern California, as well as Cedars-Sinai Medical Center, and she has been honored with the Morris Press Humanism Award from Cedars-Sinai Medical Center. So I'm really excited to welcome Dr. Weitz, and I'm going to hand it over to her now.
Thanks so much. I'm going to share my screen with you. Okay, so thanks a lot. I really appreciate the opportunity to speak with you. I wish I could be there. And when we set this up, we were hoping things would be better, but it's a pretty slow recovery from this pandemic. Things are a little better here in Los Angeles at the moment, and half our population's vaccinated. So we're hoping things will continue to improve. And I wish the same for you guys. So I'm going to talk about cold immune hemolytic anemia. This is a pretty rare entity, and there are a lot of new thoughts and new treatments of this disease. So I think it's worth really reviewing. Let's see, there we go. I do consult for Alexion, Apellis, and Sanofi, and I do receive honorarium for them. Okay. So the goals for today are to understand the different presentations of cold agglutinin disease versus cold agglutinin syndrome, and we'll discuss those differences. to understand the pathophysiology of cold agglutinin disease, the role of that complement plays in that disease, and to understand the role of complement inhibition in managing cold agglutinin disease. So you all are familiar with this smear, the one that the lab calls you and says, we can't make a good smear because everything's agglutinating in the tube. And as you can see, lots of agglutinates here, induced by relatively cold temperatures. Nuke red there and poly there. So the signs and symptoms of cold agglutinin disease do vary. There are complement-driven symptoms, and then there are agglutination-driven symptoms, and then they sort of merge. So the complement-driven symptoms are the ones you think about more frequently, evidence of hemolytic anemia. But then the patients get this acrocyanosis, okay? And those are really the cold-induced agglutination symptoms. Raynaud's phenomena, very common in cold agglutinin disease. Oops, sorry about that. And livedo reticularis, which is similar. And then they can develop gangrene. And I borrowed this slide from Dr. Berenstain, and you can see here the dark urine because sometimes they get intravascular hemolysis. Here's the agglutination in the tube at room temperature. And here you can see the Raynaud's and the cold-induced acrocyanosis. Okay, and then the remainder of the symptoms that they have, fatigue and dyspnea, the hemoglobinuria and the jaundice, usually driven by the complement-induced hemolysis. I'll show you some data from the cold agglutinin trial that suggests that fatigue, just like in other hemolytic disorders, is not just hemolysis, it's not just anemia, but it's due to complement-driven cytokines. So cold antibody-mediated hemolytic anemias, the autoantibodies are very interesting. So in cold agglutinin disease, which really is a low-grade lymphoproliferative disorder, it's not necessarily malignant, but there is evidence in the bone marrow in cold agglutinin disease for lymphoid proliferation. Usually this is an anti-big I. It can be an anti-PR or sometimes an IH antibody, but 85+% of the time, if not more, it's an IgM to big I. And it affects the classical pathway. It's antigen antibody mediated with complement that then is expressed on the cells. It causes primarily extravascular hemolysis, although intravascular hemolysis can occur. And cold agglutinin disease is a disease of old people. You don't usually see it in people under 50. Most often the patients are in their 60s, 70s, and 80s. So usually seen in older individuals. In contrast to that, cold agglutinin syndrome is usually due to some other underlying process. It can be infection, classically mycoplasma, which makes an IgM to big I, but sometimes EB virus. And EB virus is interesting because it makes an antibody to little I, which theoretically shouldn't be expressed on the cells, on the red cells. Occasionally it can be to an anti-IH, but it's also seen with aggressive lymphomas. So these patients may have cold agglutinins as a manifestation of their underlying lymphoma. Typically it is IgM, occasionally IgG, and these IgMs also tend to be, in this case, in cold agglutinin syndromes, they may be polyclonal, with the exception of the lymphomas where they can be monoclonal. And they, again, involve the classical pathway of complement, and there's extravascular hemolysis, and they can occur at any age. The other cold antibody that's really fascinating is paroxysmal cold hemoglobinuria. It's very rare. I think in my career, I've seen 3 cases maybe of paroxysmal cold hemoglobinuria. It's seen in kids. Maybe that's why I don't see it that much, because I don't take care of kids. But it is seen in patients with syphilis and with occasionally with other viral syndromes, rarely with hematologic malignancies. They usually don't have agglutination because it's an IgG molecule rather than an IgM. And these IgG molecules have a biphasic thermal amplitude. So they fix at cold temperature, then they bind the complement, and they stay bound to the cell at warm temperatures, as opposed to the IgMs, which tend to float off the cells. They tend to get intravascular hemolysis, but again, it's mediated by the classical complement pathway. So there are a variety of phenotypes that can present in cold agglutinin disease. There's hemolytic anemia with some of the circulatory findings, the Raynaud's, et cetera, which can be low grade. They may just have Raynaud's. They may not have the digital ischemia. And that's the vast majority of patients. About 70% of patients will present that way. They can have hemolytic anemia with significant acrocyanosis or digital ischemia, and that's about 21%. And then there are those that have a lot of circulatory symptoms. And here you can see the variety. This is from Dr. Berenston's recent publication in Blood. And you can see that there are these, the vast majority have either severe anemia or moderate anemia. And you can see that the LDHs tend to be high, the bilirubins are high, and the IgM levels do vary, but they tend to be high. Okay. The IgM level itself, the cold agglutinin antibody or titer, doesn't predict really how brisk the hemolysis is. And here you can see these compensated ones, the IgM levels are a little bit higher, and but the LDH is somewhat lower. And here you can see they have mild anemia and the IgM level is fairly high, but the hemolysis isn't quite as brisk as in these patients. So the IgM level itself doesn't necessarily predict how brisk the hemolysis will be and how severe the anemia will be. So what are the diagnostic criteria for cold agglutinin disease? Well, you have to demonstrate that they have chronic hemolysis. So, you need the hemoglobin and all the other biochemical markers, haptoglobin, retic count, LDH, bilirubin and especially indirect bilirubin for chronic hemolysis. And then you want to see that the DAT is positive. And most of the cases, the DAT will be negative for IgG. Occasionally, there may be weak positivity, but most of the time it's negative. If it's positive for IgG, you should think about paroxysmal cold hemoglobinuria and check a Doneth-Landsteiner antibody. The antibody is directed to the P antigen in paroxysmal cold, as opposed to the I antigen for cold agglutinin disease. And then you want to check for C3d on the cells, indicating that there's complement activation. And you do want to check a cold agglutinin titer. Okay. And just remember, for you guys, you know this, but you have to instruct your general internal medicine colleagues that the bloods on these patients have to be kept warm. So either the lab, when they come up, they need to have the heat block that they can stick the blood in. In the old days, we'd stick it in our bras or we'd stick it under our arms. and walk it down to the lab, but we don't have to do that anymore. So, but just remind them that this patient, we think this patient has cold agglutinins, and you need to be able to keep this blood warm in order to get it to the lab. And then you want to assess them to see whether or not they have any malignant disease or any overt relevant infections like mycoplasma, rebivirus, et cetera. The confirmatory tests are the presence of a clonal IgM, kappa. The vast majority, 85%, are kappa. They can, on occasion, be lambda, but it's relatively rare. And again, you got to keep the blood warm or you're not going to be able to make the proper diagnosis. And then you might want to do flow cytometry on peripheral blood, which is less likely to be positive in cold agglutinin disease as opposed to cold agglutinin syndrome. So you may want to do the flow on the marrow in order to identify this low-level lymphoproliferation. Now, what about seasonal changes? Well, we were discussing earlier that it's really hard to recruit patients for the trial in Southern California because we don't get that cold. And Dr. Berenston and Dr. Roth have a lot of patients because it gets cold there. So one's in Norway, one's in Germany. So, and you could see that there are seasonal differences. It's subtle. This is from Alexander Roth's paper, and you could see that the change from summer to winter does cause a decrease in the hemoglobin in these patients with cold agglutinin disorder, and that is less in spring, goes away in summer, and you could see the bilirubins go up as well in the winter. They're lower in the fall, and they start coming down in the spring. I do have patients in Southern California. They're pretty rare. And on a day like this, it's overcast and cool, they'll get livedo reticularis and some other, and maybe some acrocyanosis. So, but there is a seasonal effect. You guys probably see that more than I do. Now, another interesting thing is that there is an increased risk of thromboembolic complications with cold agglutinin disease. We don't usually talk about that, but we know that in other immune-mediated hemolytic disorders and other hemolytic disorders such as PNH, complement-driven hemolytic disorders, there's an increased risk of thromboembolic events. We know in autoimmune hemolytic anemia, for example, if you go back to Sir John Dacey's original papers, the most common cause of death in autoimmune hemolytic anemia is not hemolysis, it's thrombosis, pulmonary embolus. And so again, thromboembolic events are very common. We know in autoimmune hemolytic anemia, there's an increased incidence of the antiphospholipid syndrome, which may be driving about 30% of autoimmune hemolytic anemias are positive for APLS, but 15% will still have thrombosis, even if they're APLS negative. So, which is why we always anticoagulate, prophylactically anticoagulate those patients. So Catherine Broom, my colleague at Georgetown, looked at the risk in cold agglutinin disease. And indeed, there were 608 patients with cold agglutinin disease as she searched the Optum. The Optum data set, and they were matched with almost 6,000 patients without cold agglutinin disease. And you can see that there is an increased risk of thrombosis in patients with CAD, with cold agglutinin disease, compared to their matched cohort without it. And the probability is significantly higher with cold agglutinin disease. and compared to their age-matched controls. So, and we'll talk a little bit about what that risk is due to. And I'll show you some of the data from the C1S study. Again, here you can see, if you look at mortality in cold agglutinin disease, death occurred at a younger age than those who did not have cold agglutinin disease. And if you had one or more thromboembolic events, your risk of mortality, risk of dying, was significantly higher. And here you can see that it's statistically significant. All right, causes of cold agglutinin autoimmune hemolytic anemia. Infection, so transient, these are usually transient. You usually don't have to do anything about it. Mycoplasma being the most common infection, EB virus mononucleosis with little I, the second most common. I know that in the US, that's a board question for internal medicine. They always ask that. So big I for mycoplasma, little I for mono. Then there's cold agglutinin disease, which may be oligoclonal or clonal, usually IgM kappa to big I, and then the secondary cold agglutinin syndromes with both low-grade and high-grade lymphomas. And here you could see, this is in cold agglutinin disease, and you could see the bone marrow in these patients. There's this lymphoid proliferation. It's not, in these lymphoid nodules, it's not really malignant. It's less than 5% of the marrow, but nevertheless, it appears to be clonal. And so we call it a low-grade lymphoproliferation. Interestingly enough, there are some gene abnormalities associated with cold agglutinin disease, and one of them is the IgVH4-34 gene located on the arm of chromosome 14. You know, chromosome 14 is important in lymphoid proliferations and malignancies, and it really encodes for the IgM heavy chain, which is present in 85% of cold agglutinin disease. In contrast, in Waldenstrom's, even though that's an IgM heavy chain proliferation, we see this IGHV3 gene instead. So if you're looking at a gene profile, you'll see that. There's also this framework 1 region of the heavy chain that's essential for recognition of the big I antigen. And the binding and specificity are really determined by this complementary determining region, the CDR3, and some changes in the light chain variable region. There are subtle differences in the light chain binding, and that may account for some of the thermal amplitude disparities that we see in the clinical phenotypes. So again, cold agglutinin disease, there's some clonal proliferation. It makes this IgM, it's an IgM that binds and complexes with red cells. So IgMs are big molecules with multiple arms, and that's what causes agglutination, as opposed to the IgG, which only has 2 arms. And that leads to complement activation, because IgMs always bind complement, and leads to extravascular clearance of these complement-loaded cells in the liver, and may account for some intravascular hemolysis as well. The thermal amplitude is defined as the highest temperature at which the cold agglutinin will react. And the pathogenicity depends on the thermal amplitude more than it does on the cold agglutinin titer. Okay. If the thermal amplitude is over 28 degrees, the red cells will agglutinate in the cooler parts of the body, even at mild ambient temperatures. And that'll lead to complement activation and hemolysis. And some patients have thermal amplitudes that are closer to 37 degrees. So it does vary extensively. So when we were talking about the principles of agglutination, that IgMs are big molecules, you can see here from this ancient photograph, this ancient publication, that IgMs, because they have 5 arms, they are sterically more likely to bring red cells together, as opposed to an IgG, which has a much smaller range. The antibodies, again, they're IgM, they tend to be clonal, kappa greater than lambda, best but they're more active at colder temperatures with thermal amplitudes that vary from 4 to 30 degrees, and they can bridge multiple red cells, and in doing so, then fix complement on the red cells. And the polysaccharides most often are big I as opposed to little I. And there are some subtle changes in the composition of the carbohydrates of the polysaccharides on the little I versus big I antigen. So how do we evaluate these patients? Again, you want to look at pre-warmed blood. You don't want the blood to get cold. And you want to check the hemoglobin, and you want to check the cold agglutinin titer, the thermal amplitude, the presence of immunoglobulin, the SPEP, and immunofixation, and then ultimately flow cytometry on the bone marrow to see whether or not there's low-level lymphoproliferation versus aggressive lymphoma. And again, you want to do these in warmed samples, otherwise it's going to get all messed up. So you have your patient sample, and here is the plasma in the patient, and you take normal red cells, okay, and at cold temperatures, the red cells will fix the antibody. They'll fix this antibody, okay? And then they'll activate complement, and they do it by activating C3, by cleaving C3. Remember, this is antigen antibody activating through the classical pathway, generating C3 convertase, which will result in the deposition of C3b on the red cell membrane. C3b will then be able to fix the terminal complement proteins that lead to the MAC complex, or the cell will get and what happens most often is it gets phagocytized by the hepatic macrophage, which has a receptor for C3b. Okay, and here you could see the C3b loaded cells, and but you can also get intravascular hemolysis due to terminal complement. 90% of cold agglutinin disease is IgM, about 3.5% IgG, rare IgA, and kappa is 90% to lambda. For non-Hodgkin's lymphoma, most of them are low-grade proliferations, but you can see CLL or marginal zone, and you can see aggressive lymphomas as well. All right, current treatments for cold agglutinin disease, and we'll talk about complement in a minute. You want to avoid the cold, so long sleeves, gloves, and hats. I know that sounds pretty crazy, especially if you're living in Southern California, but my patients will tell me that, you know, they'll go out for a run, and then if there's a breeze, if they're not wearing long sleeves, they'll get a little chill, and all of a sudden they'll have acrocyanosis, or they'll have Raynaud's. So that's important. Folic acid and iron. If they need transfusion, you want to remember to use a blood warmer. And the blood warmers are highly effective. Both the patient and the doctor in the room are sweating. They keep the blood really warm. You can do plasmapheresis because IgM is a big molecule. So it's easy to pull out. Again, you want to keep it warm so it doesn't gum up the machine. You can use erythropoietin if the retic count is inadequate. And then you can use cytotoxic agents like cyclophosphamide has been used, chlorambucil has been used. Those are more historic than anything else, but they do work depending on the underlying etiology. What you don't see on the list, there's no role for corticosteroids. They don't work. They only put the patient at risk for infection. Splenectomy, because most of the clearance occurs in the liver, or IVIG, which really isn't very effective in this disease. More recently, the goals have been to treat the underlying clonal proliferation, and probably the leading choice of drug is something like rituximab. And you can get partial responses in 45 to 65% with duration of remissions, median duration about 11 months. So CRs are rare. You can add fludarabine or cladribine, but there's a lot of toxicity associated with those particular drugs. Or you could add bendamustine, and I'll show you that data in a second. And then there are clinical trials using eculizumab, which I have a lot of experience with, but I have to tell you, I found to be less than effective in cold agglutinin disease. Sutimlimab, which the C1s inhibitor, which is much more effective to my view. And then this immune proteasome drugs inhibition that's also being looked at. Here's the rituximab bendamustine data. They had looked at 45 patients, median hemoglobins of 9.5, but you could see there was a pretty wide range. And CRs in around 40%, and PRs about 30%. The duration of response, 91% had a prolonged response to 32 months. And the Ritux bendamustine seems to be at least as good as rituximab and fludarabine, but a lot less toxic. So I think people are shying away from fludara and cladribine and moving towards rituximab bendamustine instead. And this is just Dr. Berenson's data on these drugs, and you could see the toxicity is pretty low with Ritux alone. And fludarabine, more significant toxicities. Bortezomib, the proteasome inhibitor, pretty low toxicity, but Benda Ritux seems to be the most tolerable with a median duration of response. It's pretty long. So, and the overall response, very high with the Benda and Ritux. So as I mentioned earlier, because IgMs always fix complement, extravascular clearance of these cells is the predominant feature. And that's due to the fixing of complement and the generation through the classical pathway and the generation of C3b that coats these cells, and they're cleared by the liver macrophage, which has a receptor for C3b. And that's why you can identify these cells as having C3d, the cleavage product from C3b. Okay. So what's the role of complement in this disorder? Just to remind you of the complement system, I can't see you, so I can't ask how many of you remember the complement system. When I give these talks, most of the time, most people don't remember anything about the complement system. But it's actually quite fascinating and really interesting. So I'll walk you through this. So complement's part of our innate immune system. It's very primitive. Complement's job is to get rid of pathogens. Now, pathogens can be infectious agents, it can be bacteria, viruses, it could be dead and dying cells, its goal is to get rid of these in a safe fashion or wrap them up in a clot so that you can digest, it can be digested. And it interacts with the adaptive immune system for the elimination of these pathogens. It's crucial that to develop in the development of an inflammatory response to these pathogenic agents. And the inflammatory response is intimately linked to the thrombotic process. And the complement system has a lot of similarities to hemostasis thrombosis. And then they probably developed in parallel and then diverged. But again, the goal is to eliminate pathogens. We know that the complement system is important in recognizing non-self, okay? And the opsonization by the deposition of C3b tags a non-self surface or a non-self pathogen so that it can be cleared. Remember that bacteria and viruses don't have any way of regulating this system. So once they're tagged, they're done. They're cleared out. And as opposed to humans where we have regulatory processes that can limit that. There's opsonization and clearance by phagocytosis, and you could see that here, these tagged cells. There's detection of immune complexes. Okay, so immune complexes will trigger off more complement activation, and that can produce anaphylatoxins and chemotactic proteins. So C1s, for example, activates the production of pentraxins. Pentraxins are proteins like CRP, C-reactive protein, that are important in modulating the immune response. And also inducing other inflammatory cytokines like IL-6, which is very important, and IL-10 that are very important in chemotactic activity. And they also interact with the hemostatic system to induce thrombosis. We also know that the complement system can directly activate through C5a, can directly activate thrombin generation. So there's a lot of interaction with both hemostasis as well as the inflammatory processes. So here you can see phagocytosis through the deposition of C3b, inflammation through C3a and C5a, and thrombosis, especially through C5a, and cell lysis through generation of the terminal complement complex. So all of these conspire to destroy a pathogen. The problem is it's very primitive and it's very non-selective. So you have to be able to regulate these processes in order not to destroy your own cells. And here you can see another, the classical pathway through antigen antibody, IgG, or in the case of cold agglutinin, IgM, activating the C1 complex, C1q, R, and S, which then generates, binds C4, generating C4b, and also cleaves C2 to generate C2a, C4b, which is C3 convertase, converting C3 to C3a and C3b. C3b then coats whatever cell it binds to and fix two C3bs, and a fragment from factor B will act as C5 convertase and push the system forward to cleave C5 to C5a and C5b. C5b fixing the terminal complement complex, punching a hole in a membrane, makes a micelle in the membrane. and which is inhibited by CD59, and which is missing in diseases like PNH, for example. And then C5a, which is a potent inflammatory and prothrombotic protein. So all of these conspire to activate the complement system. Now, as I mentioned, CD59 is a natural inhibitor and is missing in PNH. C3b is modulated by a variety of processes complement receptor 1 will modulate how much C3b you have on your cells. CD55 inhibits the generation of the formation of the C5 convertase so that you can generate more C5. And CD55 is missing in PNH as well. And then there's factor B and factor D, which form the alternative pathway, so that you always have a little bit of C3b present on the cells. We know that complement activation is part of the early immune response and contributes to the pro-inflammatory state. We know that TNF, IL-6, IL-8, IL-10, IL-17, they're all increased in complement-mediated diseases. And there are increased vascular markers as well. As I mentioned, C1s induces the release of pentraxins. We see this complement-mediated inflammation and cytokine activity that really correlates with fatigue severity. We see it in chronic fatigue syndrome. We see it in other hemolytic disorders, such as PNH. And when you inhibit the complement in PNH, for example, the fatigue dramatically increases, independent of the improvement in hemoglobin. Here you can see in HUS patients, hemolytic uremic syndrome patients, marked increase in soluble TNF receptor 1 and VCAM as well compared to normal healthy volunteers. There wasn't much known about inflammation in CAD. We did talk about the thromboembolic complications. And we do think that IL-6 plays a predominant role in inflammation, especially in some of these other hemolytic disorders. And here you can see some of the interplay that may happen. So again, you have the complement system with C3 convertase, and C5 convertase. So C3a there's a receptor on platelets for C3 and C5a, and the C5a receptor on the platelet is crucial to platelet activation. There is also, again, the C5b, which can cause terminal complement deposition on the platelets, and the platelets will then form a micelle of C9 and vesiculate, and those are very thrombogenic. And we also know that these inflammatory components will then interact with the generation of tissue factor. We know IL-6 will induce monocyte, upregulate monocyte tissue factor expression, and both P-selectin and E-selectin will increase tissue factor expression as well, inducing thrombosis. So people looked at, early on, they looked at C1s inhibition to see whether or not it could block hemolysis in cold agglutinin disease. And indeed, in this very preliminary study, using the precursor of sutimlimab, you could see that hemolysis was ablated basically by using this drug. And again, here you could see, if you look at phagocytosis of human red cells, then you see here's the precursor. And here are the patients who have cold agglutinin disease, and you could see a marked reduction in C3 deposition and phagocytosis. So sutimlimab has morphed from TNT-003 and is a monoclonal antibody to C1s. There are a variety of places that you could inhibit the complement system in cold agglutinin disease. As I mentioned, eculizumab's been used to block terminal complement. Again, I think it's not as effective as working higher up in the system. APL2, I don't think they've looked at this in cold agglutinin disease. I believe there's an ongoing trial in autoimmune hemolytic anemia. And it is a C3 inhibitor, small molecule C3 inhibitor. And then there's the C1 esterase inhibitor, which actually works by blocking bradykinin. The TNT-003 that's now morphed into the sutimlimab, and there's an annexin inhibitor as well. And this is the one that's furthest along, and I'll show you some of this data. So sutimlimab is designed to block the C1s inhibitor component of the C1 complex. And by doing so, it inhibits the activation of and cleavage of C4 and C2 so that you decrease the production of C3 convertase. It does not affect the alternative pathway, and it does not affect the terminal complement pathway other than by decreasing the generation of C3b. The lectin membrane mannose binding pathway also works through this same mechanism. And as a result, we would expect a decrease in extravascular hemolysis. So the Cardinal study, which many of you may have seen, was just published in the New England Journal, finally. With COVID, everything was being delayed. So this was finally published. And you could see that these were patients who had hemoglobins of less than 10. They had to have evidence of active hemolysis. They required a blood transfusion, at least one or more blood transfusions within 6 months of enrollment. They could not have received rituximab or any other combination therapy, rituximab within 3 months or a combination within 6 months. And cold agglutinin syndromes are excluded, so they had to have a bone marrow to rule out active lymphoma. They could have lymphoid proliferation, but it had to be less than 5%. And then it's given IV, it's weight-based, and given the day 1, day 0, and day 7, and then every 2 weeks thereafter. And this is the weight-based dosing. The endpoints were hemoglobin of greater than 2, normalization or normalization of the hemoglobin, the absence of transfusions from week 5 to 26, and then they looked at mean change, et cetera. And here you can clearly see that there's a dramatic and rapid improvement in the hemoglobin within the first week or 2 or 3, and by 4 weeks, it's up to 11. And the mean hemoglobin increase was 2.6 grams. And 83% had an improvement of greater than 1 gram. And here you could see, again, the improvement in the hemoglobin. I don't know why they didn't make this red, but rapid improvement. But look at the fatigue scores. Just like in what we saw in PNH, the improvement of the fatigue score is independent of the hemoglobin recovery. And so here you can see by the first week, the FACIT fatigue scores are up by over 10 points, okay? And so as a consequence, even before the hemoglobins really respond. And you can also see that the bilirubins drop dramatically. If you look at the IL-6 levels, then you could see IL-6 here are in red. You could see they drop by week 3. And once they're down, they stay down. Again, it's inverse to the facet fatigue, which is what we found in other hemolytic disorders like PNH. And you could see rapid improvement by the first week in the fatigue scores. And once they're up, they stay up. And if you look at the actual the Wieslab complement activity, you can see that it drops by the first week. So it's highly effective in shutting off the complement activity. And once it's down, it stays down. And if you look at the C4 levels, which tend to be low because of consumption, they rise and they normalize and stay normal. So suppression of the CP activity and normalization of the C4 were sustained for the 25 weeks of the study. If you look at IL-10 levels, again, again, very similar results to what we saw on the previous slide with IL-6. Again, these tend to decrease over time and correlate inversely with the improvement in the fatigue scores. And here you can see the recovery of the hemoglobin. And again, the fatigue scores improve very rapidly, even before the hemoglobins recover. So this really hasn't been presented yet, but I thought I would tease you with this. So as part of this study, we did look at D-dimers and antithrombin 3 complexes in these disorders, and you could see that they tend to be high in patients with cold agglutinin disease. And this is at week 26. You could see there's a marked reduction in D-dimer, and there's a reduction in TAT. And again, this is what we saw in the PNH data, and I think this will hold up in the C1s data over time, suggesting that, again, no patients had thromboembolic complications while on the trial, and they were not treated with anticoagulants unless they had had a previous thromboembolic complication. So just to summarize, cold agglutinin disease is a rare autoimmune disorder. The signs and symptoms result in cold-induced agglutination and complement activation and complement lysis. Most of the patients have a low-level lymphoproliferation. Benda and Rtux appear to be the safest chemotherapeutic agent, but complement inhibition rapidly improves the hemoglobin, reduces the transfusion requirement, improves the facet fatigue scores, reduces the cytokine activation, and reduces the markers of hemostatic activation. And I'll stop there, and I'll be happy to take any questions.
Thank you so much, Dr. Weitz. While we await for some additional questions, I have a couple I wanted to get started with, if that's okay.
Yeah, sure.
So first of all, I wanted to ask you about your experience using complement inhibitors while patients have complement-mediated disorders during co-infection with COVID.
Yeah, so I've had 4 PNH patients. None of my AHUS patients, fortunately, have gotten COVID, but I have 4 PNH patients who got COVID. 2 were hospitalized, 2 were not. 1 was intubated. And what we did was most of my patients are on Ravu. So they're at varying stages relative to their Ravu infusions. But we just gave them, if they had evidence of hemolysis, which they did, if they all did, we just gave them a dose of ECU to tide them over until their next Ravu dose. If they were due for Ravu within the next week or so, we just gave them the Ravu. But we did not have, nobody died. and they all made it through. The data, there was talk early. There's a lot of data from Cornell about complement activation in COVID. There's some recent data that appears to show from Rob Brodsky's group that, in fact, factor D inhibition is highly effective in shutting off the thromboembolic complications and the complement-mediated problems in COVID. But that, the trial with ECU was not particularly promising. The problem is the timing of it. When do you give it? And so it's a little complicated.
Fair enough. The second question I have is about this association with fatigue. Clearly, fatigue is responding very quickly to treatment. Do you find that fatigue is a good indicator for when your already diagnosed patients are having an exacerbation as well, as a warning sign that something is coming that may be then biochemically detectable after the fatigue?
Yeah, I think that's probably true. We know, for example, in other immune disorders like ITP, the patients will tell you they know their platelets are down because they're really tired. And if you look at the fatigue scores, you look at the IL-6 levels, they're high. So yeah, it is a marker for complement activation. And I think there is going to be, Catherine Broom is leading this, a C1s trial in refractory ITP or relapsed ITP, which should be very interesting. It's an antigen antibody mediated disease, so it makes sense. Yeah.
So I invite everyone to take a moment to complete our feedback survey. If you have a question, please feel free to unmute yourself and ask. While we're waiting, I also have another question for you. What do you do for anticoagulation in patients with active cold agglutinin disease? Do you do prophylactic anticoagulation or not?
Well, we never used to, but now that the data's out, yes. And that's what we did in autoimmune hemolytic anemia, for example. So we had several patients who had PEs. And if you go back to the literature, indeed, Sir John Dacey identified this in like the 1950s. And it got lost over time. But if you go back in his book on immune hemolytic anemias, it's in there. And the most common cause of death in autoimmune hemolytic anemia is thrombosis. It's PE. So, and again, that when we looked at this in PNH, for example, we saw that the interaction between IL-6, dimers, TATs, they're intimately linked, and they're not related to just the LDH. So it's not just the hemolytic process. There's something else going on. It's really cytokine and inflammatory mediated. And thrombosis is very common in that situation. So yes,
I do have
prophylaxis right at the present time. Knowing this information, I would initiate prophylactic anticoagulation.
And is it only during the active stages or also just throughout the patient's journey through this process, even if it's controlled, if their markers are controlled?
Well, that's a good question. If they still have evidence of autoantibody, then you probably want to continue, at least for sure during active hemolysis. In our autoimmune hemolytic anemia patients, if they don't have APLS, concurrent APLS, we would probably stop if they're not hemolyzing. Even though if you check a Coombs test, they're still positive. I don't see them losing their positivity. So, but if they're not actively hemolyzing, then I would consider stopping. If they are still hemolyzing but compensated, they need to continue.
Perfect.
And
I know
obviously, you can use a DOAC in low dose, so the bleeding risk is low. Yeah.
I know we're at the top of the hour, but I'm hoping we can ask two more questions.
Sure,
if that's okay. One is a question about whether you would call this cold agglutinin disease or not. There is hemolysis with positive hemolytic markers like LD, Billy, Hapto being low, and with cold agglutination and blood smear, positive DAT, C3D only, but a negative thermal amplitude and a titer. So would you label that as cold agglutinin disease?
Oh, it smells like it. I would ask how the blood was collected. Maybe that's why they're not picking up the IgM. I would make sure that it was collected properly. But it smells like cold agglutinin. I mean, you're not going. The problem is you can't do plasmapheresis if you can't demonstrate the IgM, right? So, and if you don't have the complement inhibitor, you can't use that. So, it is sitting at the FDA. I'm hoping it'll be approved. There was some issue with the manufacturing, so I'm hoping that they'll get over that and approve it sometime this quarter or next.
We're eagerly awaiting to see what happens in the States.
I think it's a huge improvement over standard therapy. But yes, I think that smells like cold agglutinin. And it may just be that the titer is very low, or maybe it's an IgA. You can see IgA-mediated hemolytic anemia. I have 2 patients who had IgAs causing their hemolysis. You have to do a special assay. I was lucky enough to have the late Dr. Garrity handy, so I could send blood to him. But yeah, so that might be something else you want to check. See if it's
Thank
an
you,
IgA.
Dr. Weitz.
Yeah.
Yeah, so we do the IgA detection, and in order for that to happen, hospital laboratories can send the samples to Canadian Blood Services National Immunohematology Lab as well. So that is definitely possible to get done.
Yeah.
I have one more question for you. How do you use the titer at 4 degrees centigrade to adjust the patient management? What is the value of that titer?
Well, only if you're giving chemotherapy does it have value, really. I mean, if you're giving the C1s, we don't follow the titer because the titer is not going to change, right? So if you're giving chemotherapy, yes, the IgM will come down. I think the only value is just to substantiate or validate your suspicions. But again, the titer doesn't always correlate with the degree of hemolysis. And more important is the thermal amplitude.
Right.
Yeah.
We do have lots of discussions about titer and thermal amplitude and severity, so I'm glad we have you to answer that. We have a question here asking, for how long are patients treated? Assuming this is for cold agglutinin disease.
The C1s or the rituximab bendamustine?
I will ask Mirel to
probably give 6 cycles. But with the C1s right now, it goes on to an extension phase and they're out 2 years now. Just keep on going. So the issue is, should we combine Benda Ritux with C1s inhibition to reduce the antibody level, right? So that's the next question. We don't have any trials yet.
Let's say you only get funding for a short period of time. Is there a time frame when you would want to discontinue, or kinds of things that you can follow to figure out when to discontinue? Because I can imagine that becoming an issue in Canada.
Yeah, I would go 26 weeks because that's what the trial showed. Although when patients came off in the washout, sometimes they demonstrate recurrence of the hemolysis. As long as the antibody's there, they're going to hemolyze, right? So it's going to be an ongoing process unless you can get rid of the antibody. So, some people feel you shouldn't give a complement inhibitor with rituximab because rituximab, sometimes cytotoxicity of rituximab requires complement. We have not had that problem in other disorders. So I don't know if that's really a valid reason not to combine even just Ritux and the C1s. But that those trials haven't been done. So they need to be looked at. Oh, did I lose you? I can't
Sorry
hear
about that. I
you.
muted myself. I was going to say there's a question from the audience that sort of builds on that thought as well. With prolonged treatment, do you see expansion of the imputable source clone, like as it might happen in PNH, given that the treatment does not address the root cause?
Well, that's really interesting. You could argue, just playing devil's advocate here, you could argue that complement may be modulating the level of disease. And if you inhibit the complement, will you see expansion of the clone? Or is that just the natural history? Again, only 3.5% go on to develop high-grade lymphomas, but the clones may expand. That's a whole other issue. There was some data presented a couple of years ago that did suggest that there was expansion of the clone over time. But whether or not that was due to the C1s is unclear. Yeah, I think that's the reason that they chose patients who didn't have greater than 10%, didn't have a true lymphoma, because they didn't want to get that messy.
Right.
Okay, but
Right. That was pretty
it's
smart on
certainly
their part.
possible and theoretical, but there's not much data on that.
I see. I have a comment for you from one of our audience members. They said, number one, they loved the comment on the historic women in clinical laboratory medicine ferrying tubes from bedside to the lab in their brassieres. Secondly, we're feeling our seasonal inferiority right now. And the fact that summers are so subclinical makes you wonder if the syndrome is present in equal measure around the world, just less apparent in the warmer zones, or if there is a role played by vitamin D. Just like it might be in multiple sclerosis.
Yeah, well, that could be. But yes, I think that we probably have this disease. It's just less prevalent in Southern California than it is in Vermont, okay, or in Canada, just because we're warmer. I see plenty of patients who have Raynaud's. Should I be checking them? I don't know. Maybe, but yes, I mean, there's no question we don't see the degree of hemolysis that you guys probably see and that Dr. Berenstain sees. Yeah.
Well, you captured the imagination of 150 people today during the
great.
hour. Or greater, because sometimes people are attending in groups. So really glad that you were able to join us from a distance. And I hope everything goes well in California where you are as well, and you stay safe. Thank you so much.
We're in the orange zone now.
Okay,
so
that's
getting
good.
better. We're out of the purple zone. So, all right, stay safe, everybody. Thank you so much for the invitation. It was really fun.
Thank you.
Sure.
Bye.
Bye.